Welcome back to Decode Healthcare with Harshal. So, if you hung out with us for Part 5, you know we tackled the ins and outs of wound repairs. Well, today, our explainer dives right into the next level of surgical coding, the specific rules for moving attached skin and skin replacement surgery. This is Part 6, Adjacent Tissue Transfer and Skin Replacement, and let me tell you, it is packed with absolutely crucial CPT guidelines.
Okay, here's our roadmap for today's explainer. 1. Moving and replacing skin. 2. Tissue transfer explained. 3. The 2 golden rules. 4. Surgical prep and grafts. 5. Coding patient autographs. And 6. Wrap-up and next steps. Let's get right into it.
Section 1. Moving and replacing skin.
Let's set the stage with the main challenge coders face here. When a wound is just too large or complex for a simple or intermediate repair, how do you avoid the most common coding traps? Surgeons have to get pretty creative, right? They might stretch nearby skin over the wound, or they might even take a completely separate piece of skin from somewhere else on the body to patch it up. Now, if you don't know the specific CPT guidelines for these procedures, it's incredibly easy to accidentally unbundle codes, measure the wrong areas, and literally just build the whole thing incorrectly.
Section 2. Tissue transfer explained.
So, to avoid those billing traps, we really need to define our terms first. An adjacent tissue transfer, or ATT, happens when the surgeon cuts skin near the wound and stretches or rotates it over the defect. But hey, here is the absolute magic phrase you need to remember. They keep it attached to its original blood supply. The skin isn't completely chopped off and moved. No, it's still tethered to the body at its base, which keeps the tissue alive and healthy. In operative reports, you'll constantly see this written as a Z-plasty, a W-plasty, an advancement flap, or a rotation flap.
And when an advancement or rotation flap is performed, it's a very precise mechanical process. The surgeon doesn't just arbitrarily pull the skin, they make very specific incisions to free up a section of nearby skin. Then, they slide or rotate that exact flap over the main wound, the primary defect, and stitch it securely into place. The base of the flap remains totally connected to the surrounding tissue the entire time. That intact blood supply is exactly what makes it an adjacent tissue transfer rather than a completely free skin graft.
Section 3. The 2 golden rules. All right, now that we understand the physical procedure, we've got to talk about the guidelines. Rule number 1 is our ultimate rule maker, and I really cannot stress this enough. The excision of the lesion is already included in the adjacent tissue transfer code. You must never, ever bill the excision separately. Think about it. When a surgeon removes a skin cancer lesion and then immediately performs a rotation flap to close the hole, the work of cutting out that lesion is bundled directly into the payment for the tissue transfer. If you code the excision and the tissue transfer together, you're unbundling, and that is a massive compliance error.
Let's move on to rule number 2, which is all about the math. Seriously, how do we know which code to actually pick? For tissue transfers, code selection is based entirely on the size of the defect in square centimeters. But it's not just the size of the original wound. Step 1, you measure the primary defect, meaning the main hole you're trying to close. Step 2, you measure the secondary defect. What's that? Well, when you stretch a flap of skin over the main wound, you naturally create a new, smaller gap where that skin used to be. Step 3, you add both of those areas together to get your final measurement.
Think about how this addition works in practice. Say you have a primary defect that measures 1 by 1 centimeter, giving us 1 square centimeter. But when the surgeon advances that flap, it leaves a gap behind it, the secondary defect, which is 1 by 2 centimeters or 2 square centimeters. You literally just add them physically together. 1 plus 2 equals 3 square centimeters. That total combined area is the exact number you use to select your CPT code. Always do the math.
Section 4. Surgical prep and grafts.
Okay, so we've mastered tissue transfers where the skin stays attached, but what happens when the surgeon has to replace the skin completely using grafts? Before anyone can just slap a new layer of skin onto a wound, the surgeon absolutely has to prep the site. This brings us to surgical preparation, covering codes 15002 to 15005. Why is this necessary? Because the skin graft is completely detached from its original blood supply. For it to survive and actually take root in its new home, it needs to be placed on a perfectly healthy, bleeding surface.
So what exactly qualifies as surgical preparation? Let me be clear, it's not just wiping the wound with iodine or doing a simple cleaning. It's an intense, active surgical procedure. The surgeon is actively cutting away dead, non-viable tissue from a burn or a traumatic wound. They might be aggressively treating a necrotizing infection or cutting deep to release a severe, tightened scar contracture.
The whole goal is to create a fresh, clean, highly vascularized wound bed so that the fresh graft has a healthy foundation to attach to and heal.
Section 5. Coding patient autografts.
Once that wound bed is perfectly prepped, it's finally time to apply the new skin. Very often, the surgeon will use an autograft. Auto meaning self. This is skin harvested directly from the patient's own body to be used as a patch. When we look at autografts, there are two main categories, and you're going to choose completely different CPT codes based on which one the surgeon performs. A split-thickness autograft means the surgeon used a special tool to shave off just the top layers of skin, the epidermis, and a little bit of the underlying dermis. It's quite thin. On the other hand, a full-thickness autograft means they cut deep. They take the epidermis and the entire depth of the dermis, going all the way down to the fat layer. Full-thickness grafts are often used on the face or hands, where elasticity and appearance are just incredibly important.
And this brings us to the final, absolute golden rule of this explainer. When you're coding skin replacement surgery, your code selection relies entirely on the size and location of the recipient defect, not the donor site. Let's say a surgeon takes a 10 square centimeter piece of skin from the patient's thigh and uses it to cover an 8 square centimeter wound on their neck. You code based on the 8 square centimeter defect on the neck. The neck is the recipient site. It's the whole reason the surgery is happening in the first place. You literally never code these based on where the skin came from.
Section 6. Wrap-up and next steps.
All right, we have covered a massive amount of ground today regarding the integumentary system. If you take literally nothing else away from this explainer, you need to remember these 4 points to code these complex surgeries with absolute confidence. First, never unbundle the excision from an adjacent tissue transfer. The transfer code pays for the removal of the lesion. Second, always do your addition for tissue transfers. Primary defect plus secondary defect equals your total area. Third, surgical preparation is a distinct procedure meant to create a healthy vascular bed. And finally, keep your focus purely on the recipient site when measuring and coding skin grafts.
But hey, what happens if the patient doesn't have enough healthy skin of their own, and the surgeon has to use a biological implant, or maybe artificial skin? Well, that is exactly what we're going to dive into next time. Make sure to subscribe because in part 7 of this explainer series, we'll be tackling other flaps, allografts, and the incredibly tricky rules surrounding pressure ulcers. I will see you in the next one.